Good evening, ladies and gentlemen. We are going to just take a minute to allow everybody to come on in to enter into our virtual town hall. So welcome. We are so glad you're joining us. Welcome, welcome everyone. We're going to just wait a minute to give everybody an opportunity to join us. All right, we are going to go ahead. It is 6:30 on the dot. Good evening, ladies and gentlemen. Thank you for joining us tonight at our Center for Depression Research and Clinical Care first virtual town hall. We are so excited that you're joining us tonight. We know you could be many places and we are glad you are here. So first off, we want to get into introductions. I am Harmony Hilton. I have the pleasure of serving as the program manager of public outreach in community education. And I have only been here for a short amount of time, but I just want to say it has been fantastic. So I just want to go through all the virtual town hall format and logistics prior to our presentation. So if we can move forward to the next slide to ensure we are all aligned and we know our program. So if you have not joined us before, this may be a little bit new, but for all of you who have, we just want to let you know we cannot see or hear you. This really is a one-way stream, so your faces and names are not visible to other attendees. Please note that we do have a Q&A box to submit questions. We know in most other Zoom formats that there is the chat option, but please do not use the chat option. We are asking that you use the Q&A because we want to ensure your anonymity, and we, just in case you don't want your name attached to your question in the box, we want to keep that format so you are anonymous. So again, please use the Q&A box. Do not use the chat function. We appreciate that. So if you have any questions, we can go ahead and move forward. If you have any questions, please be aware that Sangeeta Senthuram is the individual who can answer specifically about your participation. If you are one of our partners or our participants in the study, please be aware of that. Also, please be aware that we will not be answering very specific questions. We are going to be answering more general questions. And we just want to highlight and reiterate to please use the Q&A box so things remain anonymous. Please move forward. So we also want to go over this evening's town hall agenda. We have 4 items that we want to go over. We have our announcements that are going to be done by our director, Dr. Madhukar Trivedi. We have our research. We get a look inside with Dr. Nicholas Westers. We have our discussion between Dr. Trivedi and Dr. Nicholas Westers. And then we have our Q&A session between them. So this is the point that I want to let you know and introduce Dr. Madhukar Trivedi. So we have a very special program tonight for you. Tonight, we're going to be hearing both from Dr. Trivedi and Dr. Westers, but I want to introduce our founding director of the Center for Depression Research and Clinical Care. Dr. Madhukar Trivedi is a professor of psychiatry, chief of the Division of Mood Disorders, and the director here at the CDRC at UT Southwestern. He earned his degrees in India and completed his residence in psychiatry at the University General Hospital and Henry Ford's Hospital in Detroit, Michigan. He completed his fellowship at UT Southwestern, where he now serves as the Betty Jo Hayes Distinguished Chair in Mental Health and the Julie Hirsch Chair for Depression Research and Clinical Care. He is certified by the American Board of Psychiatry and Neurology. And Dr. Trivedi is an established clinical and translational researcher with extensive experience serving as PI and co-PI on several single and multi-site trials funded by NIH, various foundations, and industry sponsors. On a very personal note, because I am fond of him, Dr. Trivedi's wry wit and humor combined with his care and his kindness that he shows to our community partners have really made me proud to be part of his team. So these attributes also make for a fantastic and intriguing podcast. So I have a shameless plug here. Please join us for our brainstorm, our podcast. So I will now hand it over to Dr. Trivedi to share the latest news and announcements in our research initiatives here at the CDRC.
Thanks a lot, Harmony. And if I can have the same next slide, I think, welcome everyone. I think this is we want to be engaged in back and forth with our partners and participants in the research studies, because without you, we can't really succeed. So our effort at these town halls is to provide some information, but also give you some feedback on the kinds of work we are currently doing, as well as new initiatives we have been launching. So while the pandemic was going on, we have launched a number of new things in order to pivot to in response to the pandemic. And more importantly, I think we were able to then move a lot more of our activities virtual, and we have several publications coming out of that, looking at how people responded, both those who have history of depression, those who are well now, but had a past history of depression. And more importantly, when we looked at people who did not have depression, but have had some issues, when we looked at their longitudinal course, we published results from that in several studies, showing that actually our participants, while this was negative in terms of the social isolation, they were able to actually navigate their depression quite well because they had connections with healthcare. Those who had actually some degree of this kind of problems, but they were able to function before the pandemic, were actually the ones more at risk. And so we recognized that those social connections and social support systems that these people were receiving before may have been the ones that held them together and were able to function. But when the pandemic hit and people had to stop the interactions, they obviously lost some of their social support, and that really led to problems. But I think that as a matter of, for the center, we've launched actually several new things. And in fact, a lot of our work has now really expanded to include the state. So 3 major initiatives we have launched. One is a research network across all 12 medical schools, looking at youth depression and suicide, and really evaluating the kinds of things that can help us develop prediction models so that at the beginning of treatment or even before, we can predict the course of illness, very similar to what people have done for heart disease and for diabetes and other things. We obviously have been engaging and continuing our work on the TRAD study, the Texas Resilience Against Depression trial, which is turning out to be now the largest such study in the nation. And so results from that were just published in several journals, and some of it we've talked about last time. And then statewide, there are 2 other initiatives. One is we in partnership with the Meadows Mental Health Policy Institute, we received the Lone Star Challenge Prize from the Lida Health Philanthropies and MacArthur Foundation. And that is really going to impact a lot of health systems, not only in North Texas, but also across the state, where we're leading the effort to try to change the way depression is diagnosed, but more importantly, treated once it is diagnosed in primary care, family practice, pediatric practice, OB/GYN practice across the state at all of the major medical centers in the state. And then we recently just got funded to actually launch a large school-based program where we are doing a 5-session hands-on experience-based program for high schoolers across the state, again, partnering with all 12 medical schools. So in general, while unfortunately the pandemic has negatively affected a lot of our partners and participants, we were able to actually move into this new realm where we have expanded our work throughout the state. We are on social media, and we, as Harmony mentioned, we have launched a new podcast called Brainstorm, Decoding Depression. So you can download this podcast anywhere you try to download your podcasts. And this, we've already now done 10 of these, and and we have planned at least twice a month. So you'll get 2 installments every month going forward. But let me move to really now the main part of our presentation. So anybody if you have any questions or any additional information you want, you can send us an email. We'll be very happy to respond. We do want to, over the next 6 months, also do town halls where we will specifically report back to all of you the results from the studies that you all have been participating in. And I think that's, again, very exciting, because that is the only way we can complete the circle. But let me move to the main attraction for today. I think that one of the things that we all know that becomes very scary for people, loved ones, and for patients, our patients, who are feeling so loss of control that they are feeling helpless, hopeless, and even thoughts of death and suicide. So when somebody is suicidal, especially a teenager, then everybody in that teenager's life and the teenager feel panic about what to do. There isn't a formula. This is not like if a 45-year-old is clutching his chest, then everybody will say, go to a nearest ER, or let's get to a cardiologist, or let's get a defibrillator in any place. This is really a place where people either are shy, are silent about it, they don't talk about it, and it really has very negative effect on everybody. But the teenager who's experiencing it is feeling the panic. They don't know what to do. This is not, again, like somebody has a problem, medical problem, they know where to go. Here it is very hard. And so this is a big challenge. And I think that I am so very pleased to have Dr. Vesters join us, because we want to start having a dialogue first, that this is something that should be taken seriously. And there are examples in the literature where people have reported that for example, a case example I've read about recently, where somebody was going up to the Golden Gate Bridge. Unfortunately, that is a source of a lot of people committing suicide. And he did not attempt or jump off the bridge, because before going there, most people have some ambivalence. Nobody really completely decides. They are ambivalent. And he, as he was driving to the bridge, said, if one person looks at me, if one person smiles at me, or somebody even gestures towards me, then I will not attempt suicide. And just that one little thing made him because as he was walking up to the bridge, somebody said, hello, how are you? And he stopped, because he had promised himself he's not going to do it. So therefore, there are many things we can do. And Dr. Vesters has been in the middle of this. His work is really very essential in trying to help teenagers as well as parents to figure out how to deal with somebody when they are in the middle of suicidal thoughts and behavior. So I'm going to let Dr. Vesters go. And he is a very valued colleague here at UT Southwestern, does his work at Children's Medical Center. And Dr. Vesters, the floor is yours.
Well, thank you very much, Dr. Trivedi, CDRC and partners for the honor actually to speak tonight. And I'm very humbled, especially talking about such a difficult, sensitive topic. And I know for a lot of people, it can be overwhelming, because we're talking about anxiety, but more specifically depression, and even suicidal thoughts, attempts, and deaths. And so if you need to take a break, I know this is being recorded, feel free to take a break, come back when you need to. And at the end, there are a couple of tips that I have listed from the American Psychological Association about being able to deal with stress. So yes, so thank you very much for this opportunity. I'm going to request remote control of the screen. And let's see, I think I have it now. Okay. So I would like to talk about the pandemic's effect on youth anxiety, depression, and suicidal thoughts in behaviors in general. And so a lot of research here. So hopefully the screens are not going to be too heavy with information. Okay, here we go. So it probably comes as no surprise that symptoms of anxiety and depression have increased among nearly all individuals, regardless of age, since the start of the pandemic. And the Lancet published this article last month, in which a team of researchers conducted a systematic review of data reporting the prevalence of major depressive disorder and anxiety disorders during the pandemic, published between January 1st of 2020 and January 29th of this year, 2021. And just 3 articles actually used a diagnostic interview to more accurately determine diagnosis, so major depressive disorder, anxiety disorder, whereas most use screening measures like the PHQ-9 or the GAD-7 to really get estimates of prevalence, global prevalence rates. In greater daily COVID infection rates, as well as a greater reduction in human mobility, so that means largely due to physical distancing and quarantining, were associated with increases in the prevalence of major depressive disorder and anxiety disorders. And females were affected more than males, and younger age groups were affected more than older age groups. So the younger you get, specifically right into the adolescent age range, high school, 9th through 12th grade is, I think, and then young adults were seen bearing the brunt of this. And more specifically, they estimated that an additional 53.2 million cases of major depressive disorder in 2020 due to the effects of COVID. This includes 35.5 million females and 17.7 million males. And you can see the visual representation here on the upper half of this figure from the publication that they published. They also estimated an additional 76.2 million cases of anxiety disorders in 2020 due to the effects of the pandemic. And this includes 51.8 million females and 24.4 million males, which is represented here on the lower half of the figure. So you can see greater rates of anxiety and depression even throughout the pandemic. And at the outset of the pandemic, I was actually most worried about individuals with pre-existing mental health difficulties. So that is that those with depression would feel more depressed due to the quarantining and physical distancing, and that those with anxiety would feel even more anxious due to fear of their loved ones or even themselves contracting COVID. And researchers in Canada, one of whom you'll hear next in our Psychology of Self-Injury podcast, there's a shameless plug for our podcast here, took a look at this. And in May 2020, they recontacted a sample of 773 college students who previously completed a survey on student mental health in May of 2019. And they found that students with pre-existing mental health concerns showed improving actually or similar mental health during the pandemic compared with 1 year prior. In contrast, students without pre-existing mental health concerns were actually more likely to show declining mental health, which coincided with the increased social isolation among these students. So basically, those with pre-existing mental health conditions, mental health difficulties, were still struggling, albeit a little bit less than before. And then now a whole new population without any pre-existing mental health conditions or difficulties started to struggle. So that's when we talk about this whole wave of mental health difficulties. And I'll say that this does parallel my clinical work, working with adolescents and families, and those who already felt depressed and alone and isolated started to see that others started to feel depressed, alone, and isolated, which ironically made them feel less alone and isolated. So that possibly could be one reason why there was a little bit less depression. And then youth with, or improvements in depression with those with pre-existing mental health difficulties. And then youth with social anxiety, and probably adults as well, loved this switch to online school, virtual learning. And this makes sense since they were able to avoid the very source of their anxiety. But then fast forward to today, now with school being held in person without as many options for virtual learning, and they're continuing to struggle. And not only are they already socially anxious, but for the past year and a half, even individuals without pre-existing anxiety have been out of practice with their social skills. They're rusty with their social skills, and it makes them even feel more anxious. And I'm seeing that a lot with the young people that I see in therapy. And other psychologists have reported similar experiences. So the American Psychological Association, or APA, conducted a COVID-19 telehealth practitioner survey of more than 1,100 psychologists from August to October of last year in 2020. and again of more than 1,700 psychologists from August to September of this year, 2021. And more psychologists reported increased demand across all treatment areas prior to the pandemic, and the increased demand has jumped since last year. So this is a busy slide, but if you can stay with me with the numbers. So psychologists reported greatest increases in treating anxiety disorders, here circled, 84%, which was up from 74% last year in 2020, which was also during the pandemic. They also found increase in depressive disorders, 72%, up from 60%, and trauma and stress-related disorders, 62%, up from 51%. And other diagnoses with large increases included sleep-wake disorders, obsessive-compulsive disorders, and substance-related disorders. And we've also seen an increase in eating disorders and eating disorder severity as well. And with respect to demographic groups, psychologists reported the greatest increase in demand among white, Asian, and multiracial populations, and among adults 18 to 64, adolescents 13 to 17, and older adults 65 to 79. And across most patient population groups, more psychologists reported treating more patients than in 2020, and fewer psychologists reported actual decreases, which indicates a higher overall demand. A study that just came out a couple weeks ago, literally like I think maybe 14, 15 days ago, looked at real-time data using the crisis text line, which many of you are familiar with. I point a lot of people toward the crisis text line. And they examined changes in crisis text patterns from March 13th to July 2020, and compared it to the same dates in 2019. And here's kind of a screenshot of one of the tables from their paper. And they found higher rates of, during their texting in this crisis, they found higher rates of reporting stress and anxiety, higher rates of substance use, higher rates of bereavement, loneliness, or here isolated, and abuse in the early part of the pandemic compared to 2019. And there were also a significantly higher volume of texts reporting bereavement, specifically for Hispanic, Latinx individuals, Black individuals, female and non-binary trans texters during COVID compared to 2019. We'll get into a little bit more of that with the minorities or the disparities. And then there are significantly more texts about loneliness and isolation from children, adolescents, young adults, females, and those identifying as non-binary or trans. Now, notice here, though, that texting about crisis concerns related to suicidal thoughts was significantly lower compared to the pre-pandemic period, which a lot of people were thinking it would be higher. Well, other studies actually showed that they were higher. So according to data from the National Survey on Drug Use and Health, among adolescents who received mental health services between 2012 and 2015, 35% received these services exclusively from school settings. So adolescents from low-income households and who are from racial and ethnic minority groups are also more likely than other students to depend on schools to access mental health services. And it was on this backdrop that a lot of people were worried about COVID and school closures because of COVID, that it could increase risk for suicide among our youth. And COVID has really revealed a large, so many health disparities within our nation. In a longitudinal study of over 1,200 9 to 15-year-olds in China, here found a significant increase in prevalence of depressive symptoms, non-suicidal self-injury, and suicidal thoughts and behaviors after 3 months of lockdown earlier in May of 2020. Interestingly, you can see there are no changes in symptoms of anxiety. So a little bit of conflicting data here. Here in Texas and Houston, researchers looked at suicide ideation and attempts in their pediatric emergency department in 2019 and 2020. And the odds of recent suicide ideation were 1.6 times higher in March 2020 compared with March 2019, and 1.45 times higher in July 2020 compared with July 2019. And the odds of a recent suicide attempt specifically were significantly higher in February, March, April, and July 2020 compared with those same months in 2019. And there appears to have been an early increase in suicide-related behaviors between February and April 2020, as you can see here. And this time frame actually corresponds with to the onset of the pandemic in the US, including initial stay-at-home orders and social distancing efforts that went into effect in March. However, in May, Texas, if you remember, began to lift these restrictions, which may have also reduced fears and concerns regarding COVID, allowed youth to return to their schedules and reduced their social isolation. But then in June, Texas saw a resurgence of cases, which triggered the reintroduction of COVID restrictions across a number of public sectors in early July, as well as renewed efforts to increase social distancing. So here, the data indicate that at this same time, rates of suicide-related behaviors also increased. But does increase in suicide thoughts and attempts mean increase in suicide deaths? And many of you may remember these headlines that globally, suicide rates actually did not decrease during the first half of last year. In fact, suicides in the US decreased significantly last year, but may have risen among minorities. And then also unintentional injury death in 2020 did increase and were largely driven by drug overdose deaths, which may or may not be accidental. So suicide deaths may have been missed. And some researchers classified deaths by drugs, alcohol, and suicide as deaths of despair. In Connecticut, last year during the lockdown between March 10 and May 20, there was a 13% decrease in overall suicide death rate compared with a 5-year average. However, there was a significantly higher number of suicides among racial minority groups, as I mentioned earlier. And a paper published in JAMA Psychiatry found that last year in Maryland, around the same time from March 5th to May 7th, suicides significantly increased among Black residents and decreased among white residents compared to the same time period in 2017 and 2019. So more specifically, suicide mortality doubled among Black residents and were nearly cut in half among white residents. So the researchers noted that Black individuals are disproportionately affected by COVID, and suicides of Black residents from March to May coincided with the time during which deaths due to COVID peaked and Maryland was in lockdown. And now we have data of the overall death related to suicide in 2020. And the CDC National Vital Statistics System shows the death rate for suicide in the US last year decreased. And the death rate for suicide was 13.5 in 2020, which was significantly lower than that of 13.9 in 2019. Again, suicide is complex, and these rates don't necessarily reflect certain populations, like we mentioned, such as racial minorities and sexual and gender minorities. And lastly, what about children and adolescents? Overall, there actually was no significant change in the death rate for suicide among both 5 to 14-year-olds or 15 to 24-year-olds. But what about multiple waves of COVID and possibility of more school closures, this uncertainty that we're still facing? And I think we just don't know yet. We don't have data for 2021 this year, now that we're going on 2 years of being in a pandemic. And so I think we still need to keep an eye out as all the risk factors are aligned for risk for suicide among both adults and youth. And I think a lot of people are seeing this in emergency rooms, as well as just clinicians being overburdened with, like I mentioned, the psychologists earlier, just it's an increase in depression, anxiety, and all of these other mental health difficulties. So APA has a few tips to manage stress. So even today, you can, take a break from the news and social media, but find 3 good things that happen to you each day. Practice self-care in 15 or 30-minute increments throughout the day. Stay connected. I think that's one of the most important things with loved ones, family, and friends, and keep things in perspective. And here are some tips for how parents can support their children. I'll let you read that and as I end my presentation. So thank you.
Thank you so much, Dr. Westers, and thank you, Dr. Trivedi. And I just want to echo what they mentioned. Please take care of yourself. It is a challenging topic. So if you need some time to step away, please do take care of yourself. And in that vein, I want to bring up something really insightful both of you said. Dr. Trivedi, you specifically have said before that suicide is the second leading cause of death among adolescents around the world. And Dr. Westers, you referenced this and mentioned before that suicide is in your recent publication, Managing Risk and Self-Harm, Keeping Young People Safe. So can both of you share your thoughts on this, on why we're seeing this rising trend on a global scale?
Dr. Trivedi, would you like to first?
I'll let Dr. Vesters respond, but I think the bottom line is we don't know why it is rising. We do know that it is rising, and there is increasing rates of depression also in the teens in the US year after year for at least the last 10 years, while the rates are not going up in Europe or other westernized countries. So something different is happening. Clearly, there is higher rates of potential social isolation, et cetera. And so more needs to be done to understand the causes. We do know that suicide is preventable. And so the idea is really to be mindful of, and at least our approach in the center has been threefold. One is we cannot wait for us to be doing this work only when there is a crisis and an urgency. So in order to try to address the first part, that is when you're in front of a situation where somebody is suicidal, a teen or even an adult, what do we do? So there are suicide prevention programs in the country, and fortunately at UT Southwestern Children's, we have a wonderful step-down unit called Spark, which actually is an intensive outpatient program for suicidal teens. Obviously, emergency rooms and inpatient hospitalization is sometimes necessary. But even before that, I think we have to, as a society, move away from just crises and serious conditions and start looking at ourselves earlier. So we have 3 programs we are doing that are addressing this issue. First and foremost, we have to really begin the process of early detection where people are, so that in pediatric practice and family practice, where the teenager goes for annual physicals or et cetera, there has to be universal screening for depression, anxiety, and alcohol and drug use. Because that is the first thing, very similar to what we do for all other medical conditions, diabetes, high blood pressure, et cetera. We don't wait for somebody to have a stroke and say, oh, maybe you have depression, high blood pressure. We measure blood pressure very early. So that's the first thing. We have to be doing universal screening. So if you are anybody in the audience, if you have a teenager that you're dealing with and they are seen by their pediatrician, make sure they're screened for depression, anxiety, suicide. Secondly, don't be afraid to ask. It has been repeatedly seen that people worry that if I ask them about suicide, that'll put this thought in their head. I don't think that's true. I'm the father of 2 boys who are now old adults, but when they were teenagers, if it was that easy for me to put my thoughts in their heads to make them do what I wanted, that would have been an easier life. Didn't happen, does not happen. I don't think that asking, in fact, what the evidence has shown is that kids find it very reassuring. They feel that somebody cares when you ask them. So that's the second thing. Thirdly, we are actually going into schools and doing universal resilience building programs. So, and Dr. Vester has mentioned some of these issues that you can actually train people to develop strengths and resilience so that they don't get to the point of suicide. So those are the ways to think about it rather than only talk about the crisis. When there is a crisis, we have to then be able to predict what to do. And there we are doing research. We have 2 major grants funded, one by the American Foundation for Suicide Prevention and another by NIMH and RO1, trying to understand the biology, looking at inflammation and stress response through blood tests, et cetera. We are developing blood tests for that, and results will come out in the next couple of years. And then we have launched a large randomized controlled trial where half of the teens will get, if they have attempted suicide, they'll get ketamine or midazolam to see if we can pharmacologically improve outcomes. And then there are traditional programs like Spark, et cetera. So it has to be seen as a larger issue and not just do a whack-a-mole pinpoint sort of intervention. We have to think of it globally. Sorry, Dr. Vesters, I went on too long, but anything you would add?
I'm thinking about some good news and bad news with new research that the World Health Organization just put out. Basically, the one I had cited in the paper that Harmony just referenced, that was the second leading cause of death among suicide being the second leading cause of death among 15 to 24-year-olds or 29-year-olds. And now 2019 data shows that it's actually the fourth leading cause of death. So suicide rates are decreasing as of 2019. So they're decreasing globally, yet they're still the second leading cause of death among 10 to 24-year-olds here in the US. And the reason for that, I'm not sure. I mean, we know that 77% or 3/4 of suicide deaths occur in low to middle income countries. And I think a lot of that has to do with just the, again, health disparities and the access to medical and mental health care, and then access to pesticides and other agents that can increase one's likelihood of dying by suicide should they choose those methods. And then as far as like why that might be here in the US still being a second leading cause of death among our kids, perhaps there's some individualistic versus collectivistic cultures in how in our culture we tend to have to do everything on our own. Asking for help is a sign of weakness. I still hear that. It's crazy. I mean, doing this for years, you think like people would stop buying into that, but that's where we still are in our culture. I know low-hanging fruit is to blame social media and access to social media and time on that. I think the data is much more complex, and it's not so much having access to it, but it's like who's accessing it and what are they using it for, and that's more of an indicator. But yes, I'm hopeful that rates are decreasing, but for, again, individualistic cultures like ourselves here in the US. And I know one of the reason rates are high is we have access to the methods, and half of all suicide deaths are a result of firearms, and it's very easy to access those, unfortunately. But
Well, thank you for that. Do you have anything else that you would like to share on this topic before we move on to our next discussion item?
I do have a question for Dr. Vesters. I think that one thing that you maybe give your approach of educating, say, a loved one, if they have a teenager that they become aware of a teenager talking about hopelessness or death or suicide. What are the steps you would guide them to take? What would be the first thing they do, second thing they do? How do they do that?
yeah, that's a great question, because I think it's often more uncomfortable for the parents than it is for their kids. And we, as parents, project that onto our kids, thinking this is going to be awkward. Well, it's going to be awkward if we make it awkward. And I think one thing I know I've had conversations with parents before is a normal thought of death in morbid themes and maybe their artwork or horror movies or just in general, versus a more concerning suicidal concern about death. And I think it's normal, relatively normal, for individuals to wonder what the world might be like without them, which is kind of like wondering what death might be like, or how it might feel to die, or what's after death. But it's not necessarily the typical thing to think about how one might cause their own death. And so for parents to be able to differentiate that and not just get worried if your kid is preoccupied with morbid themes in their drawings, stories, or movie selection or genres or music, but it's more of, are they thinking about making this happen? And so I often will recommend to parents to practice in front of a mirror, like get a script. And for me, it's just it's just more natural, but I guess I'm asking these questions on a daily basis. And so it's not as uncomfortable or awkward for me. I'm matter of fact about it. And I think parents can be the same. A lot of parents don't want to know the answers. So they may ask the question, you're not thinking about suicide, are you? Like, well, the correct answer is no, because clearly you're not okay with it. So we want to be able to make it a safe place to be able to talk about suicide. So whether it's hearing this talk today, being able to reference, I just heard a talk where suicide is the second leading cause of death among youth and and adolescents and young adults here in the U.S. And is this something that any of your friends have struggled with? So you could start further apart, so it's a little bit less close if you're really concerned that your child might not be as comfortable with it. And then you can just ask, like, is this something that you've ever thought about or struggled with, and be ready for the answer, because it could be uncomfortable and really scary. But most of the time, like Dr. Trivedi said, research shows that being able to talk about it openly and have someone ask can actually, research shows, decrease risk of suicide. It won't put the idea in their head, but if anything, it'll get them to feel more relieved in access to treatment should they need it. And so it's a tough conversation if the answer is yes. And going into problem solving mode is not necessarily the right thing to do. Just listen first and see when was the most recent time. Have you thought about what you might do? And these are kind of my typical risk assessments, but maybe your first step is just simply preparing yourself with a script of in the mirror how you might role play this or ask your child this, and then think about deeply, like, what if the answer is yes? Can you handle that? Just as if your kid, breaks their leg and they're in distress, it's parent mode. You're gonna keep your composure and help them get it fixed. But it's a little bit different when it comes to this, because it's not a broken bone as much as it's thoughts that are going awry.
But a lot of it is about in sort of being aware that you can help.
Yes.
It's very similar to kids have peanut allergies, right? And if the parents sees something happening to the child, it is scary, but they don't get paralyzed. They know they can help, so they figure out steps to take in order to get the teenager help from a medical professional. And I think that is the way to think about it.
Yeah.
And I think that you really pointed out one important thing is that your reaction also has an effect. So instead of just being panicked, I think if you have some thought going in before you react and say, I'm here to help, and whether or not the words come out as the exact right or not is sometimes less important than the emotions you express. So I think that is the other thing that you can comment on.
Yeah, I think parents, again, it's a scary thing if the answer is yes. And so they might say, well, why? Well, there doesn't have to be a reason why. I mean, like, things can happen in life, and depression doesn't need a reason why. Sadness, sometimes we just wake up around, on the wrong side of the bed. Of course, if we do a chain analysis, we can maybe look at pinpoint specific things that might increase the risk, but asking the why question is a tricky one, and I would advise against it, even though you want to know why, because if you know the why, then maybe you can solve it. But oftentimes we don't need to know the source, but we just need to be there and listen to our kids to be able to make them feel safe to talk about us now and in the future, should they ever have suicidal thoughts in the future. Because Dr. Trivedi, like you had mentioned, if it's a negative reaction, a judgmental one, you have no reason to be sad, or it's such a selfish thing. Why would you think about killing yourself? Well, if it's a selfish thing, that's beside the point. Like, your response is, it sounds like it's more of a selfish response if that's the comment, because you're trying to protect yourself in your emotions, because it's a scary thing. But
I think that's very hard for people to really digest, right? We all do our best.
Yes.
Go to a medical ward, and you see 92-year-olds wanting to extend their life, and so all of us fight to continue and extend it. And there, they have a teenager who is expressing something or just the opposite. Yeah. So it is a little jarring, but I think like with other difficult things, you prepare yourself to be available to help is the main issue.
And maybe one last comment on that is, your teenager, your child likely knows you're not going to like the answer, and so I might thank them for sharing that difficult thing and applaud them for how difficult it might have been, or how brave they must have been scared to share that. And I think that can really decrease the tension for both of you in that case. And because it can be hard.
And I think prior to that or after that is the work of really getting into treatment. Yeah. Getting improvements, helping them build their strength. It may not be something that they are able to do. It may not be something that parents can immediately help, but there's help available. There are therapists who are really very good at doing this, helping the teenagers deal with their negative emotions and help them develop strengths around it. So do not be afraid to get into treatment. So if you take the teenager or an adult gets into treatment, it doesn't have to be never ending, and people can get out of it and have a normal life. So
And I think a lot of parents actually, or a lot of teenagers are hesitant to go into therapy, one, because they feel like it's something means that there's something horribly wrong with them. But no, you just as going to the dentist for dental cleaning or dental procedures, the normal thing to do to take care of your teeth or your eyes to the optometrist or ophthalmologist, going to a therapist is the normal thing to do when in these cases, and normalizing it. But a lot of teenagers think that once they're in therapy, they're forever in therapy. So sometimes I encourage parents to say, at least give it a try, even for a few sessions, and we'll find the right therapist. And it doesn't have to be something forever that you're in forever. But I want to make sure that you're able to talk to someone in addition to me that is more objective than I can be in these circumstances.
10 to 15% of teenagers in a high school, for example, will experience depression or anxiety at some point. And imagine I work with schools, and we talk to schools to say, let's screen for depression, and they go, whoa, whoa. And I have to remind them that schools now never actually, they routinely evaluate their vision and their hearing for students. Nobody questions why that is important. The reason it is important is because they have recognized that somebody is not able to hear or see clearly, they cannot learn. And the job of the school is to teach them, educate them. So that is coming in their way to get educated. Similarly, depression, if a teenager is experiencing depression or anxiety, that will interfere with their learning. So therefore that should be done. And so I think at least we are trying to encourage schools, and we have in the last 3 years actually reached about 15,000 students in the Dallas-Fort Worth area. And the statewide program that I'm just launching is very ambitious. We are aiming to get 200,000 students over the next several years screened and getting the resilience building youth aware of mental health program.
I love that, because many times we get referrals from the schools for students who are not allowed to go back to school until they've been seen by a mental health professional to do a risk assessment. But at the same time, a lot of these can be done at the school level. And I know there are school psychologists, there are school counselors, there's a concerns for liability, but at the same time, I think if they can do the minimum and do a screening and ask the questions, do they need to go see someone of higher level care, or is this something that that is not interfering with their learning and they're not so negatively affected that they can function here? Then I hope schools are receiving these interventions and programs that you're implementing really well, because as a clinician, I appreciate it, because it's hard when it's like, oh, you don't need to see me. Like you're good to go back to school, and I think the schools can bear part of that burden, or not burden, but
that is where that is where most students actually spend most of their time in a life, their teen lives, and so that is where we have to go. Otherwise, we wait for them to come to the ivory tower, then what we are ending up with a small proportion of people who get the care.
Yeah.
Remainder then get ignored. There is generally half the people with depression in the United States never get diagnosed. We do not tolerate this kind of thing for any other medical illness. So we have to be moving away from that. So Dr. Besters, if a teenager is listening in, or a parent is thinking about what to do in terms of the period before a teenager is suicidal for treatment, etc., how would a parent suddenly finds out that it's their child? First, can you talk a little about what you would advise parents and the teenagers to look for as early signs of depression, anxiety that often precede suicidal ideation?
Yeah, I think the pandemic has really set things up for this because it really pushes people indoors, isolation with the physical distancing, decreasing in-person interactions, which is oftentimes what we'll see with as a symptom of depression. And so a lot of people are in isolation and then this uncertainty. And then people were connecting more online. So with these apps and social media, like we were actually I was actually encouraging parents and teenagers to connect and get on their phones and use them to connect with others, Skype with grandma or Skype, but grandma might have Skype, FaceTime with your friends. And so doing that. And then what I told them to look out for, and I think it still merits like mentioning here, is are they still on their phone just as much as before? But if so, how are they using it? Are they using it just passively scrolling? People will call it doom scrolling and just absorbing passively negative information and news. Or are they using their phones to connect? And if they're using it to connect, then okay, like we can work with that. But if they're suddenly just on their phones all the time and they're not connecting with anyone, then that's going to be, and that's a change in their typical functioning. That's one thing that I get worried about. And then their grades, of course, I think everyone struggled a little bit last year doing virtual learning, at least academically. I just don't know anyone that was thriving doing virtual learning that wasn't already doing virtual learning like through homeschooling before the pandemic hit. So I think everyone struggled a little bit there. But at this point, if grades are continuing to decline and it's unlike your child, or they're sleeping more, changes in appetite, these are typical symptoms that we look for. And I think the advice that I would give to teenagers is sometimes we can be depressed without realizing it. Sometimes we can feel anxious without realizing it. But sometimes we might think we're depressed and we're not necessarily depressed, or it could be just typical response to sadness, whether it's bereavement, losing a loved one, or having a breakup. That's a typical sadness that can eventually lead to depression. But if these are things that are interfering with your day-to-day functioning, going on for weeks at a time, and you're not finding any relief, then that's when I would say to seek out a mental health professional, whether through the pediatrician, primary care physician, family physician, or going online and looking at different therapists that take your insurance or calling your insurance and finding out recommendations that way.
I think the hour is late. We can
Yes, we actually have a few questions. If
Okay.
both, so one of our audience members wants to ask, can a sudden increase in stress and anxiety cause digestional issues, symptoms, or other such symptoms? How does one counter this?
Well, symptoms often manifest physically, like stress, anxiety, whether it's stomach ache, nausea, diarrhea, digestive issues. I mean, like there's a very close link in serotonin receptors in our stomachs, but I think relaxation exercises are really important. Self-care, taking deep breaths. A lot of people say, "Oh, deep breathing doesn't work for me." They take like 3 deep breaths really fast, and of course, it doesn't work. It's not going to calm you. It's an intentional, like it's going to take minutes, time where taking deep breaths in through your nose, out through your mouth. Progressive muscle relaxation. Therapists can work with you on that, where you tighten muscles starting with your toes and then relax it and pay attention to the difference, and then work up the muscles all the way, up your body and through until you get to your face. You scrunch your face. That's a strategy. If you have the deep breathing, you can do some mindfulness exercises, guided imagery, or just your own imagery of a peaceful place or positive memories. There's some research looking at savoring as far as like memories and experiences, and just thinking about them and contemplating them, savoring them, that can improve stress and mood and also help with sleep.
I think all of us benefit from having a regular sleep-wake cycle and a circadian rhythm, right? But people who have anxiety or are experiencing anxiety symptoms, even if they don't have an anxiety disorder, for them, maintaining some kind of routine is very important, so that the sleep time is reasonably around the same time. There is physical activity and exercise. You're paying attention to how much of your time is spent in isolation or social media as opposed to social interactions. So trying to drive at some balance, being mindful, exercise, breathing exercises, physical activity on a regular basis, better nutrition, in decreasing alcohol, decreasing caffeine, are the kinds of things that you got to first try, especially for those people who have a tendency to experience anxiety or even depression. And often people don't, as Dr. Vester has meant, that is how I actually got got into the research on exercise. You know, as you know, we've done some of the big studies for exercise and depression and drug addiction. And the way I got into it is I was at that time, I used to have my clinic at St. Paul, and generally everybody at that point had recognized that those people, like from the Cooper Institute, even we had published, if people are physically active, they have less rates of depression. Nobody knew what is the cause of effect. So we said, we'll try to study it. So I was starting a study, and one patient I had who I had seen for a long time was very proudly telling me repeatedly, I exercise regularly. And so then, thankfully, I was looking out from the window, and I saw him walking on the walkway up where the shuttle goes. And next time he came, I said, I saw have you been exercising? He says, yes. I said, when do you do it? He says, I go walk up and down there. I said, that's not exercise, that's stroll in the park. So you have to really, when people say I maintain sleep-wake cycle, but they go to bed at 12 after having watched 3 hours of TV, that is not sleep-wake cycle. So being mindful and trying to be very careful about it are the kinds of things that routine sort of cycles are very important for people who are at risk for anxiety or depression. Well, I think our hour is coming to an end. So first, let me thank Dr. Vester. Thank you so very much. I think our participants and patients really benefit from these discussions and from having somebody like you who really deals with this regularly with teens and their parents. Your input is phenomenal. Thank you very much for doing this. This is an important topic. On the other hand, I always maintain, and I always like to end with this, is that talking about depression should never be depressing. Remember, there are wonderful treatments available. We just have to make sure that the person goes and stays with it. The first treatment might not work, the second may be needed. That's true for all medical illnesses, all the way from influenza to allergies, to diabetes, to hypertension, to Alzheimer's. So that is true everywhere, but I think treatments work, and don't give up. Thank you, Dr. Vesters, and Harmony.
Thank you.
You have exactly
Thank
2
you.
minutes to close shop.
Thank you all so much for joining us. We really appreciate your time. Have a lovely evening.